When an intervertebral disc in the lumbar spine ruptures, the displaced material mechanically compresses the adjacent nerve root. This condition, lumbar disc herniation, is a primary driver of radiculopathy and low back pain worldwide. It is one of the leading causes of global disability. The 2022 guidelines from the North American Spine Society offer broad parameters for surgery, recommending intervention for progressive impairments or intractable pain. But in clinical practice, the exact threshold and the precise timing to cross from medical management to the operating room remains highly subjective. Most patients begin with a standard trial of conservative care. This typically involves a regimen of targeted physical therapy, nonsteroidal anti-inflammatory drugs, and epidural steroid injections. But when clinical transitions rely on a surgeon's subjective feeling rather than quantified data, the timing of intervention becomes a gamble.
If that intuition is wrong, the patient risks navigating a window of compression that could lead to permanent nerve damage. To build a more objective model, we can look to a 2025 systematic review designed to identify definitive, quantifiable thresholds for surgical intervention. This PRISMA flowchart details the study's filtering process. Researchers distilled over 6,000 global records down to 20 high-quality studies representing 3,689 patients. Geographically, these cohorts span North America and Europe, ensuring findings reflect biological realities rather than the isolated biases of a single institution. By aggregating these global outcomes, the researchers filtered out individual clinical subjectivities and identified the actual markers of success and failure. The goal is to process this global dataset into a concrete, evidence-based decision matrix for surgery that any clinician can follow. Building this matrix starts at the foundation, isolating the absolute baseline clinical requirements for surgery found across the global data. This is a decision matrix showing the most consistent prerequisites. The first nearly universal requirement is advanced imaging confirmation. 18 of the 20 studies demanded this before considering the operating room. Clinicians are looking for specific structural deficits on an MRI or CT scan. They measure the size of the herniated fragment, classify the extrusion type, and calculate the ratio of spinal canal stenosis. The second bedrock indication filling our matrix is intractable radicular pain. This was a primary surgical driver in 17 of the 20 studies analyzed. In this clinical context, refractory has a specific numerical value. Surgical candidates typically reported a visual analog scale pain score greater than 7, persisting despite targeted medical and physical therapies. Interestingly, sensory deficits like numbness or tingling in the leg were only reported as primary indications in 8 of the 20 studies. The data shows they are too inconsistent to form a bedrock rule on their own. Any conversation about transitioning a patient to surgery must start with these two verifiable axes: structural confirmation on an MRI and unmanageable quantified pain. Across clinics, the most frequently cited trigger for surgery is a failure of conservative therapy, yet the data shows this phrase is dangerously ambiguous. To measure exactly how ambiguous, researchers applied a statistical tool known as the Index of Qualitative Variation, or IQV. This scatterplot maps the IQV scale. A score of 0 indicates uniform agreement across the medical field. A score of 1 represents maximum diversity. When mapping how clinics define failure of conservative therapy, the resulting IQV is 0.96. A score of 0.96 means the definition of a failed treatment is almost entirely dependent on institutional bias. One clinic might declare failure after 3 weeks of persistent pain, while another demands 6 months of physical therapy before considering surgery. This extreme heterogeneity suggests that currently, a patient's treatment path is often determined more by which hospital they visit than by their actual physiological state.
Because failure is a statistically unreliable metric, we have to look past the terminology. Instead, we must examine exactly how much time elapsed before a successful surgical intervention actually occurred. Shifting focus from subjective definitions to hard temporal data provides the clarity the field needs. This timeline charts the actual duration of conservative care attempted before a patient was cleared for surgery across the global cohorts. The data reveals a massive, dominant cluster of surgical interventions occurring precisely at the 4 to 6 week mark. Within this 4 to 6 week block, a true trial must take place. This means the patient receives a supervised combination of physiotherapy, nerve blocks, and active medical management. We can contrast this optimized window with the study outliers, cohorts where patients were pushed into 6 months or more of non-operative care. The data exposes a frequent crossover effect. Patients delayed for months often ended up requiring surgery anyway. Their final clinical outcomes matched the early surgery groups, but they endured months of unnecessary pain to achieve the exact same result. The synthesized data confirms that artificially prolonging conservative care past 6 weeks for patients with refractory pain offers no statistical or clinical benefit. There is one critical variable that overrides this standard timeline and alters the decision matrix entirely: the presence of motor deficits. Specifically, the data flags patients exhibiting moderate to severe weakness, graded as a 3 or lower on the Medical Research Council Muscle Strength Scale. For this specific subset of patients, the traditional wait-and-see approach of conservative management is actively dangerous. 2 prospective studies within the review, led by Thre and Thre, specifically tracked the urgent surgical windows required for neurological recovery. This chart graphs the probability of complete motor recovery against the time elapsed from symptom onset. It shows widely divergent outcomes based purely on how quickly the decompression surgery was performed. Operating within 48 hours to 8 days for severe deficits yields greater than 90% motor recovery rates. However, when surgery is delayed beyond 6 weeks, neurological recovery plummets, resulting in prolonged symptoms and poorer outcomes. The biological mechanism here is strictly mechanical. Prolonged physical pressure permanently damages the nerve root's microvasculature. Once ischemia sets in, late decompression becomes futile. This physiological reality strictly applies to severe weakness. Patients with minor or no motor issues can safely tolerate the standard 4 to 6 week conservative window without risking permanent damage. In the presence of significant motor weakness, surgical delay is not conservative care. It actively degrades the patient's physiological ceiling for recovery. Bringing all these data points together yields a final, evidence-based clinical algorithm. Path A is the standard protocol. Structural imaging confirmation combined with severe pain leads to a strict 4 to 6 week conservative trial before surgical reevaluation. Path B is the expedited protocol. Structural imaging combined with a severe motor deficit dictates an immediate bypass of conservative therapy, triggering surgery within 48 hours to 6 weeks. Adopting this specific quantitative matrix eliminates the dangerous ambiguity of conservative failure that currently plagues the field. While conservative management must remain the starting line for most lumbar disc herniations, objective data must dictate the exact exit ramps. These timelines are not passive suggestions. In cases of radiculopathy, timing is a biological variable. By replacing subjective delays with this evidence-based matrix, clinicians can optimize surgical resources and protect the patient's long-term neurological outcome.